Today we'll discuss a question from cardiology. An 80-year-old man comes to ED with gradually increasing confusion and shortness of breath. ECG shows 2:1 AV block with a ventricular rate of 40. In order to localize the site of block, the physician made the patient to do vagal maneuver, during which there is no change in the block. He then gave 500 mg atropine and the conduction ratio %. Where is the likely site of conduction block? The options are AV node, his Purkinje system, left bundle branch block, sinoatrial node. Unable to give comment from the data given. So we'll analyze the question. So it is an 80-year-old man coming with a 2:1 AV block with a ventricular rate of 40. Now we have to localize the site of block, whether it's atrioventricular nodal block or below the node. So it's a nodal block or infranodal block. So it is for that we are making the patient do the vagal maneuver as well as giving atropine. So if it is responding to the vagal maneuver, which means if we are doing Valsalva, since the AV node has good autonomic innervation, it usually responds to increase in the vagal tone. But the distal conduction system does not have this autonomic innervation, much like the AV node. So if increase in vagal tone by the Valsalva will worsen the block, it is AV nodal block. But if it is having no change, it's an infranodal block. So from that vagal maneuver in this patient, it has not changed the block, which means it's an infranodal block, it's not an AV nodal block. Since this patient has an infranodal block, this vagal maneuver or the vagal tone or the Valsalva maneuver does not change the block. Now what else is done to the patient? We are giving atropine and the conduction ratio worsened. So in infranodal block, atropine will worsen the heart rate. But in AV nodal block, atropine can improve. Atropine can increase the heart rate. But infranodal block, it will worsen the block. So that is the concept here. So this is an infranodal block, particularly in his Purkinje system. We'll talk a little bit in detail about various arrhythmia, heart block, and also both tachyarrhythmia and bradyarrhythmia. So first of all, let's understand what is sinus arrhythmia. Sinus arrhythmia, it may seem a little bit paradoxical. It's also sinus and it's arrhythmia. So what is meaning is sinus, meaning the rhythm is originating or electrical activity is originating from the SA node and then it's going to the AV node. Then through the bundle of His and the right and left bundle, it's going to the Purkinje and to the ventricles. So the origin is from the SA node. There is no change in that. But there is arrhythmia. It can be physiological during your respiratory cycle. What is happening is during your inspiration, the negative intrathoracic pressure, it becomes more negative. So the right heart filling increases. So you have increased volume coming to the right side. So the baroreceptor, it responds to the change in volume. Due to increase in volume, it responds by increasing the heart rate. Now with expiration, what happens is you have reduced filling to the right side. So the baroreceptor respond by increasing the vagal tone and reducing the heart rate. Now it can be pathological also with fever, hyperthyroidism, etc. But usually if it's physiological, you don't have to treat. Now when it comes to other tachyarrhythmias, you mainly have SVT, you have VT and you have AF. So how do you differentiate and how do you manage? So in SVT and VT, it's a regular QRS complex tachycardia, wherein the QRS is narrow in SVT and it's wide regular in ventricular tachycardia. Also in ventricular tachycardia, there is a complete AV dissociation. There are terms called fusion beat, capture beat happening in VT with complete AV dissociation. Now the treatment differs because in SPT the choice is adenosine and in VT the choice is amiodarone. This is when the patient is stable and they don't have any other comorbidities. Especially with adenosine, you have to see if there is any history of asthma. If so, you have to choose verapamil. But if the patient is unstable and presenting with this VT, you have to first give DC cardioversion. DC cardioversion means synchronized cardioversion. Now, what is the difference between a synchronized cardioversion and an unsynchronized cardioversion or defibrillation is that defibrillation is done when the patient has no pulse. Okay, it is to, you can think it as like activating the heart back or keeping the heart back to track. But DC cardioversion is to re-establish their rhythm. It is done in a synchronized manner corresponding to the R wave in the ECG. So that is done when the patient is unstable. Suppose the patient has a low BP, SBP less than 90, and the patient is cold and clammy, the patient is not responding, then you have to maybe go for DC cardioversion. So that is with the SVT and VT. SVT mainly adenosine. If there is a history of asthma, go for verapamil. VT, you give amiodarone. And if the patient is in shock, you have to give DC cardioversion. Now coming to AF, there are 2-3 scenarios in AF. So in AF, we say that AF begets AF, which means as AF becomes more chronic, it is very difficult to revert back to its normal rhythm. So that is why we say AF begets AF. So if it's of a very short duration, it has a good prognosis and we can revert back to the rhythm. The problem with AF is it can lead to embolic phenomenon because the atria is not exactly contracting. There's no effective contraction. So it can predispose to thromboembolic phenomenon because there can be clot formation and it can get dislodged. So in order to prevent that, based on the chart-to-VAS score, you have to also anticoagulate the patient if the chart-to-VAS score is high. Now to convert it back to the normal rhythm, if it's of a very short duration and there is no structural heart disease, what you opt is flecainide. Flecainide is a class 1 drug. It is a sodium channel blocker. Flecainide can only be used in structurally normal heart. Now this is important because if you give in a patient who is already having heart failure or other cardiac dysfunction, flecainide can be dangerous. So flecainide is a pill-in-pocket approach. That is, if the patient can identify when they are having that palpitation and irregular rhythm, they can take it when they feel the thing. They don't have to take it daily. They have to take it when they are getting the AF attack. Now, if the patient is having AF for a short duration, but it's not a structurally normal heart, then the treatment of choice is amiodarone itself. Now, there is another scenario when the AF is so chronic that there is no hope of getting it back to the normal rhythm. Then the option is only to control the rate, especially in AF with FVR, what we are talking, that is AF with fast ventricular rate. You have to only control the rate. You don't have to focus on controlling the rhythm. You have to control the rate. Now for rate control, the treatment of choice, the first line would be bisoprolol, which is a beta blocker. But again, a red sign or a red flag sign is asthma. In a patient of asthma, choose digoxin over bisoprolol. So AF in a structurally normal heart, flecainide. In a short duration AF, if the rhythm control is possible, choose amiodarone. If it's a very chronic AF and rhythm control is not possible, choose rate control with bisoprolol. And if there is a contraindication to bisoprolol like asthma, choose digoxin. Now this is about AF. Again, AF coming with this shock, you have to cardiovert the patient. So that is about SVT, VT and AF. Now we'll talk a bit about bradycardia as well. So bradycardia again can be sinus bradycardia, which means that the sinus rhythm is maintained, but only the rate is low. Less than 60 is considered bradycardia, but again can be physiological. In a patient who is athletic, who is having intense physical activity, they have the rate set to a normal low. So if the patient is asymptomatic and in sinus brady, after ruling out other possible causes, you can keep the patient as they are. It does not require any treatment. Otherwise, bradycardia can be due to hypothyroidism or hypothermia, so or drug like beta blockers, digoxin. So you have to rule out these causes. Now, so that is about bradycardia. Now coming to conduction block. Now conduction block means there is some problem with the conduction through the normal conductive pathway, which is the SA node coming to AV node, then to the bundle of His, then right and left bundle, and then to the Purkinje fibers. That is the normal conduction pathway. There is block somewhere in the pathway that is called conduction problem. Conduction problem is mainly classified into first degree heart block, second degree heart block, and third degree heart block or complete heart block. Now in first degree heart block, there is only a delay. So it is slow, but it is normal. So there is P, there is QRS. So the conduction is happening from SA node, it is carried over to the AV and as usual, but there is some delay. There is usually a normal physiological AV nodal delay, but here the delay is even more. It is even slower. So usually the PR interval that we tell is around less than 200 millisecond, but if it's more than 200 millisecond, it's called first degree heart block. So there is P, there is QRS, but the PR interval is prolonged. There is no skipping of QRS. Every P is followed by QRS in a first degree heart block. What happens in second degree heart block? Second degree heart block, again, there is type 1 and type 2. Type 1 is a named phenomenon. It's called a Wenckebach phenomenon, which means that there is progressive prolongation of PR until one QRS is dropped or until one P is not conducted. Now we'll see a picture and understand what it is. So here the PR is a bit prolonged initially. It becomes more prolonged in the second, and the third the QRS is dropped. Again it repeats. The PR interval prolonged, it becomes more progressive, and one QRS gets dropped. So that is a Wenckebach phenomenon or a second degree heart block type 1. Type 2 means there is some conduction not happening. We can't predict. There is no like some PR followed by QRS and some PR not. Again, it can be a 2:1, a 3:1, so and so, which means for every 2 P wave, there will be 1 QRS. So 1 P will be conducted, 1 P will not be conducted, again another P will be conducted. So when you look, you can see that the P and QRS are in a 2:1 ratio. For every 2 P, there will be 1 QRS, like that. So alternate P are not conducted, so you can say. Or there is 3:1. That means every third P wave is conducted, or a 4:1, like that. Now this is, type 2 second degree heart block is also dangerous because it can any time go in for a complete heart block. Complete heart block means the SA node and the AV node or the ventricle are no longer under the control of SA node. So the complete dissociation, which means the atria is contracting on its own, the ventricles are contracting on its own. So we have some P, some QRS. There is no association between the P and QRS. It is conducting on its own fashion. So that is called the complete heart block. Now heart block you can see in an inferior wall MI. It can be various other situations as well, like infections like Lyme disease. You also have to remember neonatal lupus, congenital heart block. It is due to anti-Ro antibody, and it's also in Lyme disease. It's a transient AV block. In inferior wall MI, why there is a heart block is because inferior wall MI is due to the right coronary artery occlusion. Right coronary artery is supplying the AV node in majority of the patients. That is why with inferior wall MI, you look out for heart block, or usually bradycardia, heart block. Everything happens with inferior wall MI, so you have to see that. So that is about heart block and arrhythmia. We'll put out a table here. So for sinus brady and sinus tachy, usually they are the sinus arrhythmia are usually physiological, but it can be pathological also. Now coming to AF, in a structurally normal heart, go for flecainide pill in pocket approach. If it's a short duration AF, you can give amiodarone in a structurally abnormal heart. If it's a chronic AF and rhythm control not possible, go for rate control with bisoprolol. If there is contraindication, use digoxin. In SPT, you go for adenosine. Again, if there is history of asthma, go for verapamil. In VT, you go for amiodarone. But if the patient is unstable in any of these cases, go for shock. One more highlighting thing I have to talk about is WPW syndrome. WPW syndrome means there is an accessory pathway. Other than your bundle of His, there is a bundle of Kent. Usually through the right to the right ventricle, there is a bundle of Kent which is connecting the atria with the ventricle. So there is a faster path rather than your AV nodal delay and a slow path. This is a bit more accelerated path because there is an accessory pathway. So in ECG, what you find is there is P, there is QRS, and this interval will be short. As I told, it's an accelerated pathway, so its PR interval will be short. Contrary to what you see in heart block, the PR interval will be long in heart block. But WPW, there is an accessory pathway. You're reaching the destination faster, so the PR interval is shorter, and there is slurring in the QRS. So that is what is WPW. And for WPW, you do not give digoxin and you do not give verapamil. What happens with digoxin and verapamil is that they block the normal conductive system, so that the accessory system will get more conduction, and it will worsen the WPW syndrome. So do not give digoxin, do not give verapamil. In WPW, procainamide is the drug of choice. Rather than amiodarone, it's procainamide, more preferable to amiodarone. It's not that amiodarone cannot be given, but procainamide is more preferred over amiodarone. The definitive treatment for WPW syndrome is the ablation of the accessory pathway. But medical management includes procainamide, which is preferred over amiodarone. Now there is another thing. If the patient has some structural disease which can predispose them to fatal arrhythmias like VT or VF, which is the common cause of sudden cardiac arrest in terms of rhythm, abnormal rhythm, which leads to sudden cardiac arrest and death, is VT or VF. So if there is any structural disease which can predispose to these fatal arrhythmias, they should have an ICD, which is an implantable cardioverter defibrillator, which means it is placed into the person's heart so that it detects abnormal rhythm and it aborts the rhythm, so that it does not go in for an VT or VF. So that is an ICD which should be placed, especially in patients with HOCM, which is hypertrophic cardiomyopathy, obstructive cardiomyopathy, which again can predispose to fatal arrhythmias and lead to early death and sudden cardiac death. So they can undergo ICD placement. So that's all. Thank you so much. We'll come back with another question.